here to discuss ERAS guidelines. So here are my objectives. So description of ERAS or enhanced recovery after surgery. It is a multidisciplinary structured approach which provides standardized evidence-based components of care to patients undergoing specific types of surgery. So this leads to a reduction in complications and hospital stay, improvements in cardiopulmonary function, earlier return of bowel function, and earlier resumption of normal activities. So successful implementation of ERAS protocol requires proper coordination between the surgeon, the anesthesiologist, the nursing personnel, the patient, and the people looking after the patient. So here is a diagrammatic representation of the emergency laparotomy pathway showing specific and contiguous pre, intra, and post-op components. This is in ERAS emergency laparotomy guideline, and I'll be discussing this part by part. So first is the preoperative in the emergency laparotomy. In the preoperative phase of an ERAS protocol for emergency laparotomy, this aims to rapidly correct alterations in the patient's physiologic homeostasis. The management of physiological derangement should occur alongside investigation and diagnosis. So surgery is a key component to correction of the underlying pathology, and when appropriate should occur without delay. So first is the counseling or education. Patient and family education and shared decision making. Patients and families should have the opportunity to discuss the risk of surgery with a senior physician prior to surgery. Counseling should be informed by a validated risk score, but with a clear understanding that have limitations and apply to individual patients. A clear, concise, written, informed, or decision aids combined with verbal patient education should be provided to the patient and family before surgery if possible. Right. So patient optimization. Optimization consists of two parts. We have the patient optimization and the system optimization. So regarding availability of facilities and efficient care pathways. So the physiological arrangements at presentation include a marked stress response, gut dysfunction, insulin resistance, fluid shift, sears, and sepsis with varying degrees of organ dysfunction. So these derangements require early recognition and management with a sense of urgency. So patients who undergo emergency laparotomy represent only a fraction of the total volume of emergency general surgical cases. So all patients for emergency laparotomy should be assessed with a validated sepsis score as early in their presentation as possible. This should be repeated at appropriate intervals in line with severity of signs and sepsis risk stratification guidelines. So question for you are the scoring guidelines. We have the sepsis guidelines that recommends the use of the quick sepsis-related organ failure assessment or the QSOFA. This is a screening tool to identify patients who are at risk of developing sepsis and septic shock. So a positive QSOFA score should prompt further investigation for organ dysfunction. So the QSOFA score, we have limitations for emergency surgery and the use of early warning score to identify deterioration due to sepsis outperforms sears and QSOFA score in one large study. So compared with elective surgical patients undergoing a comparable intra-abdominal procedure, emergency patients are increased risk of venous thromboembolism or VTE. They should be assessed for risk with a validated tool at admission and VTE prophylaxis. If pharmaceutical prophylaxis is not an option, mechanical prophylaxis should be used. So the patient should be reassessed at regular intervals, pre and post-operatively. Next, we have the sedative medications. This should be avoided pre-operatively to avoid the risk of microaspiration, hypoventilation, and the addition of benzodiazepines or other sedative agents compound. This risk should be avoided and can increase the risk of post-operative in older patients. Pre-operative nasogastric tube insertion should be considered to an individual basis assessing for the risk of aspiration, and gastric distension, depending on the pathology and patient factors. So the use of nasogastric tubes in elective colorectal surgical patients is declining as the evidence base has shown an increase in complications such as respiratory infections and pharyngolaryngitis as well. So the use in the emergency setting is very different with a risk-benefit ratio depending on the clinical circumstances and cause of abdominal pathology and patient factors. So patients may have pathology causing gastric distension and high gastric fluid volumes, and decompression may be beneficial and reduce the risk of aspiration at induction of anesthesia. So intraoperatively and postoperatively, the aim is of an EROS protocol for emergency laparotomy is to identify and rectify the primary surgical pathology and correct the physiological derangements due to the pathology and associated surgery. So the goal of anesthesiologists is to provide safe anesthesia while addressing the physiological disturbances caused by the pathologic process. So resuscitation prior to, during, and after surgery is critical to the management of patients undergoing emergency laparotomy. So volume overload can lead to perioperative complications such as organ dysfunction, ventilator dependence, gut edema, and poor wound healing. And too little fluid risk, poor organ perfusion, and associated consequences such as renal failure. So there is an early study in the guidelines that showed that patients who receive 0.9% saline compared with LR in hemorrhagic shock experience a higher incidence of hyperchloremic metabolic acidosis, electrolyte derangements, delusional coagulopathy, and higher overall volume requirements for adequate resuscitation. So saline-induced disturbances in acid-base balance can have a negative impact on the perioperative electrolyte management and organ and function and survival. There is also evidence indicating a negative impact of solutions with high chloride content on renal function, resulting in decreased kidney perfusion and urine out. So overall, the existing evidence suggests that balanced phase alloys may result in improved patient outcomes and reduce morbidity and mortality. So the use of 0.9% saline use should be limited, especially in higher risk patients with existing electrolyte derangements such as acidosis or hyperchloremia, and those who might require a significant amount of fluid resuscitation. Perioperative broad-spectrum intravenous antibiotics should be administered within 60 minutes before skin incision unless the patient is already receiving appropriate antibiotic therapy. So some agents such as fluoroquinolones and vancomycin require administration over 1 to 2 hours, and therefore administration should begin, if possible, within 120 minutes or 2 hours. So continuation of the antibiotics should be based on pathology and contamination during surgery. Next will be the short-acting anesthetics with depth of anesthesia monitored in older patients. So according to the guidelines, inhaled anesthetics agents remain the drugs commonly used for maintenance of anesthesia in emergency surgery. Short-acting agents such as sevoflurane or desflurane are easy to administer and monitor and allow rapid awakening at the end of surgery and return of protective reflexes. Intravenous anesthesia using target controlled propofol infusion reduces PONV. There is developing evidence that depth of anesthesia may be important in patients over 60 years of age, and avoiding volatile anesthetics overdose by close monitoring of age-adjusted minimum alveolar concentration or MAC is critical to avoid side effects such as hypotension. For the patient population undergoing emergency laparotomy, there is a high incidence of frailty and old age, which increase the risk of post-op delivery. So there is a recent study of our larger study targeting a lighter level of anesthesia depth with a BIS of 50 versus a deeper level with BIS 35 in major elective older surgical patients, found a significant reduction in post-op delirium in the lighter anesthesia. So maintenance of normothermia. So the measurement of core temperature using a reliable method to monitor the efficacy of warming measures should be routine And active warming devices and warming of IV fluids should be used to maintain monothermia. So blood product management. So according to the guidelines, infusion of red blood cells should be restrictive. The trigger will be hemoglobin of 70 to 90 ddl, with exemptions based on individualized clinical status and comorbidities. So in lung protective ventilation strategy, there is a routine use of low tidal volume, such as 6 to 8 ml per kilogram predicted body weight, and positive and expiratory PIP of more than 5 cm per water. With titration according to flow volume rules and clinical evaluation is recommended. Neuromuscular blockade should be monitored using a quantitative peripheral nerve monitor at the top to ensure adequate reversal before endotracheal extubation, with the most reliable site of monitoring being the abductor pollicis muscle. So patients should also have their glucose closely monitored and controlled in the range of 140 to 180 mgdl, preferably with the use of a variable rate insulin infusion. Urinary catheters are routinely placed for patients undergoing major abdominal surgery for fluid balance, bladder decompression, and to prevent urinary retention. So enhanced recovery protocols in the elective setting advocate for their early removal post-op to encourage mobility and improve patient comfort, and to reduce the incidence of catheter-associated urinary tract infection. Next is the multimodal pain management strategies. So this utilize primarily non-opioid analgesics and techniques that should be used when possible to reduce the perioperative consumption of opioids, which may delay patient recovery. So regular dosing of paracetamol up to 15 milligrams per kilogram every 6 hours with a maximum of 4 grams per 24 hours is a good analgesic base in all patients, except those with liver dysfunction. And all patients undergoing emergency laparotomy are at high risk of PONP due to physiological derangement and gastrointestinal insult. So the use of intravenous opioids is also common in emergency laparotomy patients and is a risk factor for PONP. So the use of opioids should be minimized using a multimodal approach. So there are several classes of antiemetic drugs, including serotonin antagonists, dopamine antagonists, antihistamines, and corticosteroids. And there is minimal harm to using most of these drugs apart from the increased risk of sedation or increasing the PT interval. So here we have the S guidelines in colorectal surgery. As we if we go to compare emergency laparotomy, they're just the same of ERAS guidelines posted in the ERAS website. So we have the ERAS guidelines for OP patients for cesarean section. They call this the ERAC, or the Enhanced Recovery After Cesarean Delivery. So this is quite different from ERAS of the abdominal surgery. So in the ERAC guidelines, there's a total of 5 preoperative ERAC elements that were identified. So on the left. Number 1 is the limited fasting intervals. So this concludes that solids up to 8 hours before cesarean delivery and clear fluids up to 2 hours before cesarean delivery. This reduces the aspiration risk while limiting hypovolemia, metabolic stress, and psychosis. So according to the ASA guidelines, it states that 6 to 8 hours based on the type of food ingested, a light meal or milk may be ingested for up to 6 hours before elective procedures. So next will be the non-particulate liquid carbohydrate loading. So non-particulate carbohydrate drink up to 2 hours before cesarean delivery. This is usually 45 grams of carbohydrates recommended. One example in the guidelines is the Gatorade, 32 ounce. It consists of 54 grams of carbohydrate. And clear apple juice, 16 ounce. So that are the examples. Next is the patient education. So handout or other standardized educational tool or interaction that includes pre-cesarean delivery instructions, what to expect during cesarean delivery, and enhanced recovery information. So ideally, the direct contact with patients with phone call or reminder or meeting before cesarean to remind patient of errors. Next is the lactation or breastfeeding education. So ideally, this structured prenatal classes with books, videos, and in-person lactation supporting the hospital. Next is the hemoglobin optimization. So all pregnant women should be screened for anemia per ACO guidelines. So women with iron deficiency anemia should be treated with supplemental orally per os, iron in addition to prenatal vitamins. Anemia other than iron deficiency should be further evaluated. So the goal here is to work with the obstetric provider team during prenatal visits to engage patient in understanding the importance of hemoglobin optimization. So next is the for the cesarean delivery. So preventing spinal induced hypotension is an important strategy to enhance maternal and neonatal outcomes in cesarean delivery. So current evidence supports the routine use of prophylactic phenylephrine infusion started immediately after injection of spinal anesthesia medications. So a crystalline fluid load of 1 liter administered immediately and rapidly after spinal injection is preferable to a preload and combination with vasopressors significantly reduces the incidence of spinal-induced hypotension. So maintaining the normothermia confers multiple perioperative maternal neonatal benefits, include reducing the surgical site infection risk, shorter hospital length of stay, and preferred methods of facilitating maternal neonatal warming in cesarean delivery include pre-outpatient warming and intra-fluid enforced air warming. So a higher ambient operating room temperature set at 23 degrees Celsius is also recommended. Optimal uterotonic administration during cesarean delivery is important to prevent and treat uterine atony and associated PPH. So it is advisable to use the lowest effective dose of uterotonics needed to achieve the navigate uterine tone to minimize the side effects. So in intrapartum cesarean delivery, 3 international units of oxytocin over more than 30 seconds and start oxytocin infusion at 7.5 to 15 international units. Intraoperatively, we should initiate multimodal anesthesia for cesarean delivery. So, neuroaxial long-acting opioid, example with is intrathecal morphine of 50 to 150 mics or in epidural morphine of 1 to 3 milligrams. So, non-opioid analgesia started in OR unless contraindicated. Ketorolac 15 to 30 milligrams IV after peritoneum close. Paracetamol IV after delivery or orally per OS before or after delivery. So prophylactic intervention, we have the prophylactic vasopressor to decrease hypotension associated intraoperative nausea and vomiting. And combination of these two prophylactic IV antiemetics with different mechanism of action. Examples which are the ondansetron, dexamethasone, and methamphetamine. Yes, yes. Ay, combination of tatlong po may pwede ito eh. Yung po yung sa So, optimal fluid management. So we have the goal-directed intraoperative fluid management is a mainstay of many ERAS pathways. So as previously stated, prevention and treatment of spinal anesthesia-induced hypotension should focus on vasopressors in conjunction with radiation. But, maliit. Medyo maliit. Sige, sir.
Ay,
So,
ano kasi?
ang ano, yes. Nag-zoom ba to?
Ayan.
Hindi na ba, ma'am?
Ayan, no?
Pwede ba dito yun? Sa projector mismo.
Sorry, ito yun eh. Kasi ito yung latest eh, no?
Matak na yung ano. Baba. Okay na. Okay. So in post-op cesarean delivery, we have the early oral nutrition. So the goal here is for early oral intake is to accelerate the turn of bowel function and reduce post-op catabolism. So early oral intake improves insulin sensitivity and mitigates the surgical stress response. So according to the guidelines, advance to regular diet, ideally within 4 hours post-cesarean as tolerated. Uh, it concludes ice chips and or water within 60 minutes post-cesarean vision to pack. So early oral intake leads to accelerated return of bowel function, reduced hospital length of stay, and no increased rates of complication. Early mobilization reduces insulin resistance, venous thromboembolic risk, and hospital length of stay. So according to the guidelines, example, 0 to 8 hours post-op, they can sit on the edge of bed, out of bed to chair, and ambulation is tolerated 8 to 24 hours post-op. So early removal of Foley catheter, early urinary catheter removal is important to support early mobilization goals. And this includes facilitating, yes po. Well, di naman, sir. Kasi wala na po yung decisional time. Opo. Yes, ma'am. Yung post-op lang po. Yung part lang po na yun. Yung zero. Sorry. At back. Sa regional po, ma'am. Opo, regional anesthesia. Either po, ma'am. Opo. No po, sir. Case to case basis. Ay, yes po. Wala. Wala tulog sa amin. Kasi yung part ng anesthesia part, hindi tayo stop. Yes. Yes. Yung part mo. Yung hindi siya laparotomy. Abdominal surgery. Yes. Dapat may. Yes. Wala po kasi so. Wala po ma'am. Nung tinignan ko po yung guideline na galing sa SOAP mismo, yung guideline. Yes. Yes, sir. Yes po ma'am. To ma'am, prevent po hypotension. After, ang base ko sa guidelines, ma'am, sabi ko, mag-preload ka po ng or immediately after spinal, after mag-induce. Sorry, ma'am. Doon lang ba? Hindi po. Wala pong sinabi, ma'am. Guideline mo. Okay. Ma'am. Wala. Yung latest mo mga 2020. Medyo nga rin po, sir. Medyo pang. Yes, sir. Okay. Ang sabi ko sa guideline mo, para daw po ma-prevent yung yes. Okay. One liter, no? 1 liter. Yes. Total. 1 liter total. Total. Bagal yun. Aba. One liter. General. Aba. Yes po. In general. Wala po silang specified club siya. Ilo sa guideline. Aba. dito sa guidelines po na to. Yes. Sandali. Ano ba? Okay. Ito pa lang po, sir. Kaya ano ko pa lang po. Yun nga eh. So for the multimodal analgesia po, according to the guidelines po is scheduled NSAID, scheduled paracetamol, and local anesthetic techniques as indicated. So example po sa guidelines is paracetamol 650 to 1,000 milligram orally per OS every 6 hours scheduled. Pwede rin pong ibuprofen 600 milligrams orally every 6 hours scheduled after IV ng ketorolac po na 15 to 30 milligrams was given after delivery in OR. Then, pwede rin po daw pong naproxen 500 milligrams orally twice a day or other NSAIDs na rin. Pwede rin pong gumamit ng oxycodone 2.5 to 5 milligrams orally every 4 hours as needed for pain lang. Then, preemptive or rescue supplemental regional blocks na po yung iba. And then, po. Parang once tolerated na po ang diet. Yun po yung ano nila. Kasi as much as possible po, early oral intake na rin talaga. Para mas yung improve bowel function. Yes, sir. To facilitate early discharge na. So next will be the facilitate early discharge. So they establish patient-oriented goals early and personalized or patient-centered opioid prescribing at discharge. Discharge planning on pod 1 should ideally include pediatric, lactation, and contraceptive planning sa OP. Ay, hindi po, ma'am. Sorry. Opo. Okay, last ko rin. Survey box. Yes, sir. Yung guidelines po na to, sir, noong 2020 pa po, ito yung latest nila. 2020 pa po. Opo. Wala pa pong update. Hindi naman po. So, ayan. Ay. Tayo. Ayun. So here are my references. Thank you. Ma'am, sorry. Ano yung binasa ko ma'am, parang no. Oh. Pure fasting, yes. Pero we can give ano naman po ma'am eh, antiemetics prior. Pwede magbigay ng mga antiemetics prior if needed na talaga ng liver issue. Yes. Next mo na. Next mo. Ayoko na balikan niya.
Sige, sa akin.
Sorry ma'am. Yes po. 2 hours. Yun po yung sabi nila. Pero may certain gram lang po. May binigay sa example eh. Sabi po nila Gatorade in 32 grams. Or clear juices. Aba. 2 hours prior. Clear fluids naman po talaga. No pulp. No pulp. Ang 32 grams. 32 grams ng carbohydrate. Ano ba dapat? Wala po sinabi. Apa. No. No.
Depende sa nature ng hair surgery. Intense pa yan.
2 hours naman. Tubig lang. Hindi po. 2 hours na lang yan. Aba.
When you stay here, it's really it's in my
God bless. Aba. Amen.
So sometimes it is just not understanding. Either free or never.
Yes. Thank you. For our next important. Gia.
Good afternoon, doctors. I'm Galang, here to present a journal report on cardiac tamponade pericarditis. So here are my objectives for today. So, quick recap. This is a case of PM, 53 female with a diagnosis of massive pericardial effusion, massive pleural effusion secondary to consider malignancy, surgical plan for pleural pericardial window, anesthetic plan, JETA. So for the clinical question, among patients who underwent pericardiectomy under general anesthesia, what are the risks of having post-operative complications? So for this journal, I use PubMed as my search engine, and using advanced search, the following key terms were included: anesthesia, pericardiectomy, and complications. So here are the comparison for my BIOM. So for the journal, patients with constrictive pericarditis, for the case, patient with pericardial effusion, pericardiectomy under general anesthesia, post-operative complication, and the method of case series. So are the study results valid? Were the patient groups being compared sufficiently similar with respect to their baseline characteristics? Yes. And was the follow-up sufficiently long and complete? Yes. So in this journal, it is stated in the materials and methodology part that um, retrospective single-center clinical study at a university hospital was done, and the study was approved by the ethics committee. And from July 2018 to May 2022, a total of 66 consecutive patients who underwent pericardiectomy or constrictive pericarditis were analyzed. All the methods were performed in accordance with Declaration of Helsinki, and the following parameters were collected from the patient's medical records: the age, NIHA classification, comorbidities like hypertension, coronary artery disease, diabetes, previous MI, pulmonary arterial hypertension, AV, congestive hepatopathy, and etc. And then for the third question, were objective and unbiased outcome criteria used? Actually, it was not stated in the journal. And was there adjustment for important prognostic factors? Adjustments were done, including the pericardiectomy alone and the pericardiectomy plus other cardiac procedures. Within the study period, 40 patients received an isolated pericardiectomy, and the remainder of the patients underwent pericardiectomy in combination with other cardiac procedures, including valvular surgery, coronary artery bypass grafting, tumor resection, and pulmonary artery surgery. So what were the results? How strong is the association between the exposure and outcome? So this table showed the post-operative complications reported in this journal, and the incidence of post-operative complication was 57.58%, including infection, re-exploration, acute kidney injury, tracheotomy, and low cardiac output. And then how precise are the estimates of likelihood? The journal considers 95% confidence interval, meaning that the result was statistically significant. And then assessing applicability, are there biologic issues that may affect the applicability of this study? Yes, for comorbid and then pathology, since preoperatively 50 patients had signs of congestive hepatopathy, 39 patients had history of NIHA class 3 or 4, and then almost more than 50% of the patients had a diagnosis of atrial fibrillation, and then other comorbidities including coronary artery disease, DM, hypertension, and patients with previous myocardial infarction. And then all these patients showed having left ventricular diastolic dysfunction and underwent a pericardiectomy in combination with other cardiac procedures, including valvular surgery, coronary artery bypass grafting, tumor resection, and pulmonary artery surgery. So for the discussion, constrictive pericarditis is characterized by the pathologic changes of the pericardium that occur over time with chronic inflammation, pericardial fibrosis, calcification, and stiffening leave the heart unable to fully expand and fill, resulting in ventricular constriction. So these pathophysiologic changes in diastolic filling leads to right heart failure and systemic congestion. So patients often present with lower extremity edema, poor exercise tolerance, and hypoproteinemia. Another important pathologic change of constrictive pericarditis is myocardial atrophy that can occur from myocardial infiltration and fibrosis, which impairs ventricular diastolic filling and affect the systolic contraction, thereby contributes to the development of heart failure. So, patients undergoing pericardiectomy are at a high risk of left heart failure. So, meticulous intraoperative fluid management is critical to the overall success of the procedure. So, a recent study shows that in patients undergoing pericardiectomy, the total amount of intraoperative fluid is correlated with the patient's outcome. So in this case series, all patients underwent strict preoperative fluid management with a weight loss of 5 to 10 kilos. So as most patients were on chronic diuretics, the urine output was followed during the case, and for off-pump pericardiectomies, the target urine output during the procedure was greater than 100 ml. The systolic BP was also maintained greater than 90 millimeter mercury to ensure adequate renal flow. And then close monitoring of the central venous pressure also helped to guide management decision. And then many patients were noted to have elevated central venous pressure around 15 to 20 millimeters mercury prior to the surgery. And then after pericardiectomy, the central venous pressure was kept below 8 millimeters mercury. Post-operatively, it is also important for patients to maintain. Ano pa? Hindi po. Yung parang nangyari po kasi ito is yung ang sa discussion part nila, yung ginawa nilang management po dun sa patient, parang to prevent po yung mga possible complications. Hindi po, ma'am, systematic review.
Anong study? Anong klaseng study?
Pinis ko na po siya sa ma'am, farm. Case series po. Apo, case series po siya. Na pinag-compile lang po. Yes. Parang in conclusion lang po kasi, ang sinasabi lang nila is, in conclusion po kasi, parang sinasabi lang po nila, usually, lahat po kasi nakita kong journal, yung pericardiectomy po kasi is under parang MAC local lang. Tapos, yung case po kasi na meron po kami is under JETA. Actually, ito lang po yung nakita kong case na pericardiectomy under JETA. So, yung parang discussion lang po dun sa journal is ano yung mga possible complications if nag-underwent po sila ng general anesthesia sa pericardiectomy. Yung parang naging result lang po nila is, conclusion lang nila is it depends pa rin po preoperatively sa mga kung gaano na po yung ano yung mga comorbidities niya, ano na yung status ng patient, parang gano'n.
Kasi you're discussing about
Yes. Okay. Ito na lang. So in conclusion, constrictive pericarditis is a disease that often leads to severe systemic disease as a result of impaired ventricular relaxation. And while pericardiectomy is the treatment of choice, the mortality and morbidity of pericardiectomy is higher than that of other cardiac surgeries. Preoperative comorbidities, including heart failure, liver diseases, are known to affect outcomes and should be taken into account when planning the anesthetic. And anesthesiologists must have a thorough understanding of the physiology of constrictive pericarditis to prevent common complications and utilize advanced monitoring, including TEE and CBP, to prevent intraoperative management and improve patient outcomes. Thank you.
of the teeth.
Good afternoon, everyone. Today I'll be discussing about the anesthesia in cholecystectomy and colorectal surgery. So for the general objectives, we need to discuss open cholecystectomy and laparoscopic cholecystectomy, comprehend the pathophysiological effects of during laparoscopic cholecystectomy, discuss the anesthetic management and techniques for cholecystectomy, and discuss the anesthesia and perioperative management for colorectal surgical patients. So for open cholecystectomy is a surgical removal of the gallbladder and is frequently performed for procedure for symptomatic cholecystectomy, especially in developing countries because of either lack of the laparoscopic equipments or the expertise. So in this procedure, we also can perform cholangiography, which is a dye is injected in the biliary tree via catheter and X-rays are taken in order to know if there are certain stones inside the gallbladder or in the biliary tree. So if there are any stones, choledochotomy or common bile duct exploration is done for the purpose of extracting the stones. So for the summary of the procedures, cholecystectomy, the position is placed, the patient is placed in supine position and the allowable surgical time is 45 to 90 minutes with closing consideration of muscle relaxation and minimal to 250 expected blood loss. Common morbidities in this patient includes post-op bile leak, pancreatitis, bile duct injury, cardiac and respiratory complications which are rare. Next one is laparoscopic cholecystectomy. So laparoscopic cholecystectomy remains the gold standard procedure for symptomatic gallstones due to the following stress response, post-operative, reduced post-operative pain, reduced post-operative wound infection rate, reduced intraoperative bleeding, reduce in the impairment of respiratory function, and pulmonary complication, short recovery time, and for cosmetic appearance. So laparoscopic cholecystectomy may be contraindicated in patients with uncorrectable coagulopathy, severe COPD, and severe cardiac disease. In addition, patients with prior abdominal surgeries or patients with acute cholecystitis are at a higher risk of conversion to open surgery. So this is what I have said earlier, the contraindications for laparoscopic cholecystectomy. So we're going to discuss the pathophysiological effects during laparoscopic cholecystectomy. So physiologic effects of pneumoperitoneum. So carbon dioxide was shown to be affected by increasing the intra-abdominal pressure above the venous pressure, which prevents carbon dioxide resorption, leading to hypercapnia. So when there is hypercapnia, it activates the sympathetic nervous system, leading to increased blood pressure, heart rate, and arrhythmias as well. So increase in intra-abdominal pressure may compress venous vessels, causing initial increase in preload followed by sustained decrease in preload. So during the procedure, intra-abdominal carbon dioxide insufflation causes atelectasis, therefore decreasing the functional residual capacity, increasing the PaCO2 and decrease of pulmonary oxygen. Therefore, it is contraindicated in patients with severe respiratory disease or those with COPD or those with poor cardiac function. Respiratory effects, increase in intra-abdominal pressure shifts the diaphragm cephalad and therefore it reduces the diaphragmatic exertion. This results in closure of smaller airways leading to what I have said earlier, the atelectasis. So it reduces the
reduction, therefore there is reduction in lung volumes, decrease in pulmonary compliance, increase in peak airway pressure, ventilation perfusion mismatch, and reduce thoracic compliance.
I-contraindicate ko. UV. Bakit contraindicate siya?
Hindi ko alam kung sino yung ituturo.
Sino ba dapat na?
Hindi ko alam.
Kaya lang. May
Thoracic. So during sige po. So for this patient, for laparoscopic cholecystectomy, patients with COPD, patients who are with COPD are predisposed to experiencing decreased lung volumes due to increase in the intrathoracic pressure. Therefore, the functional residual capacity po, ma'am. FRC.
yung FRC.
Decrease eh. Functional residual capacity lang. JV. Si JV po. Grabe. Territories.
Doon ako nakakaano. Doon ako
Um, functional residual capacity, expiratory reserve volume po, and vital capacity. Um, so respiratory effects, there is reduction in lung volumes, decrease in pulmonary compliance, increase in peak airway pressure, ventilation perfusion, or VQ mismatch, and reduce in thoracic compliance. So, increase in intra-abdominal pressure shifts the lungs to a cephalad and therefore reduces the diaphragmatic exertion, which results in intraoperative atelectasis. So it decreases the functional residual capacity, and the upward displacement of the diaphragm leads to the non-dependent part of the lung, which is the ventilation perfusion mismatch with higher degree of intrapulmonary shunting. So higher intra-abdominal pressure reduces the thoracic compliance and may therefore cause pneumothorax and pneumomediastinum due to the increase in the intra-alveolar pressures. So for the cardiovascular effects, increase in systemic vascular resistance, mean arterial pressure, and myocardial filling pressure with a little change in the heart rate. So it decreases the heart performance, but it does not affect the cardiac output. Hemodynamic changes includes alteration in the arterial blood pressure, arrhythmias, cardiac, and also cardiac arrest. This cardiovascular changes depends in the interaction of several factors, including the patient's position, the neurohumoral response, and cardiorespiratory status of the patient. At intra-abdominal pressure, levels greater than 15 millimeters mercury, venous return decreases, leading to decreased cardiac output and hypotension. Bradyarrhythmias are attributed to vagal stimulation, and increased concentration of carbon dioxide and catecholamines can create tachyarrhythmias. Effects on other systems. Cerebral blood flow has been shown to increase significantly during carbon dioxide insufficiency. Pneumoperitoneum, it reduces renal cortical medullary blood flow, therefore is associated with decrease in GFR and urinary output and creatinine clearance. Reduce in portal blood flow, which may lead to transient elevation in the liver enzymes. So for the summary of the procedure, patient is positioned supine with surgical time of 0.5 to 2 hours and minimal blood loss. The common morbidities include bile leak, common bile duct injury, hemorrhage, infection, injury to the bowel, and major vascular injuries which are uncommon. Complications include post-operative nausea and vomiting, shoulder pain, respiratory due to post-operative complications secondary to the pneumoperitoneum. I wasn't able to tackle it here, ma'am.
Obese patient with the COPD.
Yes po.
Okay.
When trend po, naka-trend ba? Ay, reverse trend po pala, reverse trend pa. Right side up po, to visualize, for better visualization of the surgical field. When the patient is positioned reverse Trendelenburg po, it cardiovascular wise, it increases the cardiac output, increases po ma'am. Decrease po pala ma'am, sorry. It decreases the cardiac output.
See your second year resident.
Yes po sir.
So that, yeah, okay.
Yes po sir.
So, I think we're turning about here. I think someone here. This was. We record this one.
Yes po.
Some of the failure.
Yes po ma'am. During insufflation po, because of the pressure in the intra-abdominal pressure, there can be increase in there can be tachyarrhythmias, increase in blood pressure din po, and possible, it can possibly cause hypotension po and decreased cardiac output po as a result of reverse Trendelenburg position. Because of decreased venous return po. In patients who are unfortunate. No, ma'am. They are, as what I have mentioned here in the report, they are not good candidates for laparoscopic procedures po, including laparoscopic cholecystectomy. Yes, ma'am. Um, 10 to 15 po, ma'am. It can be as not more than 15 millimeter mercury po, ma'am. Not more than 15 millimeters mercury po yung nabasa ko. Irritated. In the normal care. The normal range po is 5 to 10 centimeter water, so more than 10 centimeter water. Um, no, ma'am. 5 po, ma'am. Yes po, ma'am. Ah, malaki.
40.
10 to 20.
Every breath about 12 pounds.
5 to 10 and
12 to 40.
5. Airway. Yes po, ma'am. 5 to 10 centimeter water po for patients with normal lungs, and then 10 to 20 centimeter water for patients with airflow obstruction, and for ARDS patient, 15 to 30 centimeter water. General anesthesia. General anesthesia with endotracheal intubation for controlled ventilation is the most common anesthetic technique for laparoscopic cholecystectomy. In short procedures and in certain patients, ventilation using supraglottic airway device can be used as an alternative, specifically the ProSeal laryngeal mask airway in non-obese patients.
So we can, why?
Yung, di ba yun yung nag-adapt na dun sa ano, sa gel?
Very about
Yes po, ma'am.
That's the report.
Um, Ayan. For for this po ma'am sa ano ko po sa Jaffe po yung iba and sa may journal din po. The journal was yes po ma'am. Anesthetic management for laparoscopic cholecystectomy. Wala doon eh. May list ba nung ano? Hindi. 2012 po ma'am. Yes. So, here, versions. Okay po. Yes po. Yung protein meron natin. So, best. Okay po.
Wala siya sa
Wednesday. Now
Yan po, ma'am.
of the different we can change for that whole year. Di ba kailangan
Yes po, ma'am.
correct?
Yes po, ma'am.
For it. Bigyan mo kami ng bigyan mo kami ng
LMA brand. Yes po, ma'am. Sa brand. Brand. Okay. Very good. Eye gel. So for the regional anesthesia, thoracic epidural anesthesia and analgesia offer superior perioperative analgesia compared with systemic opioids. It decreases the postoperative pulmonary complications and decreases the duration of postoperative ill use. So complication from this from applying regional anesthesia, specifically the epidural anesthesia in patients undergoing laparoscopic cholecystectomy, there is shoulder pain due to the diaphragmatic irritation from the carbon dioxide pneumoperitoneum, and significant and most important problem is inadequate relaxation of the abdominal musculature. So spinal anesthesia is also a safe and effective anesthetic technique for cholecystectomy, which can provide post-operative analgesia and commonly done in uncomplicated open cholecystectomy. Yes, ma'am. Sige po, ma'am. Okay po, ma'am. Sige po, ma'am. So, for anesthesia in colorectal surgeries, yung the rest po kasi man puro mga anesthetic techniques for cholecystectomy using the same journal code.
So colorectal surgery is a commonly performed for colorectal cancers and other pathologies such as diverticular and inflammatory bowel disease, chemicolitis, iatrogenic perforation, and volvulus. Preoperative medical conditions may predispose colonic tissue hypoxia due to smoking, atherosclerosis, cardiac failure, and sickle cell anemia. During perioperative period, colonic blood flow is affected by blood gas composition, volume status, intra-abdominal pressure, and intraluminal pressure. So for the preoperative preparation, antibiotic prophylaxis. It is said that antimicrobial prophylaxis with aerobic and anaerobic coverage reduces surgical site infection by 75%. And preoperative nutrition and carbohydrate loading. Anemia, electrolyte imbalance, nutritional deficiency, specifically hypoalbuminemia and weight loss should be identified and corrected. For nutritional status, particularly hypoalbuminemia, is associated with increased postoperative complications, infection, and increase in hospital stay. Preoperative oral carbohydrate loading has been shown to reduce preoperative patient discomfort, postoperative insulin resistance, loss of muscle mass, postoperative nausea and vomiting, and improve muscle strength. Gum chewing mimics feeding and promotes peristalsis via neural and hormonal mechanism and increases the secretion of gastrointestinal juices and bowel motility, therefore reduces postoperative paralytic ileus. Intraoperative anesthetic management. So the goal is perioperative anesthetic management for colorectal surgery or surgical patients to minimize stress, immune responses, and maintain systemic and colonic blood flow and oxygenation. So perioperative use of beta blockers and alpha-2 agonists may be useful, particularly in high-risk patients. For patients po undergoing colorectal surgeries po. If indicated lang naman po, ma'am. Clonidine po. Methyl dopa. If indicated po ma'am yung nandito, I wasn't able to present. Yes po, sir.
Kasi you're recommending manage rate kasi
Yes, sir.
we're gonna be some of them
Yes, sir.
so you can we're going to recommend ba
Yes, sir.
kasi this anesthetic management you have to be sure so then kailangan sure ka din sa management paano ito bibigyan
Yes, sir.
type of patient
Sir, it wasn't specified here. The journal po says that the perioperative use of beta blockers and alpha-2 agonists may be useful, particularly in high-risk patients. However, routine use is not recommended until large studies showing clinical benefits in this specific surgical populations are available. Yes po, ma'am. Ito, ma'am.
Set mo naman.
Hmm. Yes po, sir.
Alam ko na ba? Ano, pero explain ko na. Hindi sila
The goal.
Still here is also preoperative anesthetic management surgeries or imaging stress and immune responses. So, maintain systemic and
Yun yung sinabi ko. Sinabi ko, mention ko siya kanina.
Iba lang 2016.
Yes po, ma'am.
Mga 22.
Next report.
Ikaw yung wait na rin. May last.
Stay with that.
Sige po. Yes po. Ma'am, wala po kasi sa barrage ng specific topic po, pati sa ano. No, ma'am, yung specific po na laparoscopic cholecystectomy na procedure po, ma'am.
Regardless mo It's just the difference is we're taking out the differentiating, like for colon. It's basically you're supposed to be describing to us what we expect we're not going to expect. Now,
Yes po, sir.
we just have to ginawa ng colon kasi yun yung colon yung ginagawa. Yeah, okay.
Yes,
So
sir.
basically, you're supposed to be reporting to us. Report that was about surgery. It's a robotic surgery.
Yes,
So,
sir.
hindi na kailangan ng colon, it's just
So, labas.
Kasi para mas makarelate kahit po din.
Yes po, sir.
Ako sa'yo kayo nagbibigay ng statements. And then without knowing, without reading, without understanding. Kaya kasi sabi ko sa inyo, nag-respond kayo, pwede ba basahin yung report? That's the it's for you to read the topic. Read on the topic. Not topic, read on the topic. Kasi pinabasa nyo yan, without actually knowing the report. Kasi the purpose of the report is on the report topic. Kasi mamatik, kaya bago mga report, which is not the objective. Okay?
So good afternoon. Good afternoon, Dr. Sai, Castro. I will be discussing about the case management for hiatal hernia. So the objectives are to present a case about hiatal hernia, to evaluate the risks associated with it, as well as to discuss the anesthetic management. So for a sample case, patient CM, 43 years old female, with a diagnosis of hiatal hernia, and was referred to us for laparoscopic repair of this hiatal hernia. Patient is a known case of hiatal hernia since 2010, manifests as early satiety and bloatedness. So consult at PGH where endoscopy done and was given for omeprazole from noted slight relief and opted to observe. However, during the interim, patient was noted to be apparently wet until 1 week prior to admission. She consulted at our OPD and admitted for EGT. For the EGT done, it showed hiatal hernia. So patient is a known asthmatic relieved by salbutamol with no other comorbidities. Patient has allergy to seafoods as well as chicken, non-smoker, and legit drug use. For the laboratories of RBT normal, on X-ray, clear lungs. On the WAB CT, it was unremarkable other than the thoracolumbar spondylosis. EGD done showed hiatal hernia, chronic gastritis, as well as pneumonitis. Patient was seen at the ward, conscious, coherent, not in distress, with stable vital signs. Patient weighs 66 kilos with a BMI of 28.19. On PE, no burden. So patient was classified as one as a with good airway. For the plan, this patient to be induced under Jetta RSI. So for hiatal hernia, the herniation is the part of the stomach into the thoracic cavity, of which the hiatus is seen in the diaphragm. Usually, patients who are obese have a increase in the gastric pressure, which will increase the frequency of the transient lower esophageal sphincter relaxation. Patients who are obese usually or may have hiatal hernia formation as well as because of gastroesophageal reflux diseases. An increase of 3.5 kilogram per meter squared in BMI is associated with at least 2.7-fold increase in risk of developing new reflux symptoms. Patients with hiatal hernia are usually asymptomatic and usually hindi naman po kailangan i-repair. This hiatal hernia usually results from weakened anchors to the gastroesophageal junction to the diaphragm, as well as increase in the abdominal pressure. So for the risk associated with hiatal hernia, the number one associated is increase in the risk of developing new reflux symptoms. Patient with hiatal hernia usually aspiration risk. It is also part of the top 10 predisposing factors to aspiration. This would include since some of the patients are also obese, nadadagdagan yung aspiration risk. So a combination of hiatal hernia as well as GERD, as well as delayed gastric emptying with increased abdominal pressure will have the risk of severe pneumonitis should aspiration would occur. So esophageectomy usually is done for these patients with malignant esophageal lesions. Pero for those with hiatal hernia now, these are usually done by laparoscopic approach. And most of the complications would include cardiovascular in nature. So for the management, since these patients are at risk for aspiration, they should be given at least a prokinetic, metoclopramide or ranitidine to decrease the gastric leakage. They should also be subjected to at least 8 hours fasting to promote gastric emptying. So so the plan is RSI since they have aspirations. And then for those other comorbidities within the patient, they should maintain euvolemia. If ever the patient is subjected for esophagectomy, they may be given thoracic epidural analgesia. For the post-operative complications, it would include aspiration, sepsis, shock, or anastomotic leak, or recurrent laryngeal nerve injury. For patients with hiatal hernia alone, no other comorbidities or diseases, usual post-op meds would include opioid only. That is all of it. Aspiration lang.
That ends our conference. And so, sir, yung ano ba, introduce natin yung mga pre-res.
Summary daw.
In summary, patients with hiatal hernia are at risk for aspiration. Some of the patients who have hiatal hernia also have gastroesophageal reflux as well as obesity, which are also part of the top 10 factors predisposing to aspiration. Yes. If the hiatal hernia is large enough, it may compress the heart. Kaya base. Esophageectomy. Yes, po sa Patient is at risk for hypoxia. Respiratory depression. Respiratory depression. Hypoxia, since this patient would have a at least decreased functional residual capacity as well as decreased compliance. Restrictive. It's more of restrictive lung disease. Restrictive. Pag-diagnose ito lang. Wala. Ano ba? Hiatal hernia alone po, ma'am, no. But since usually they are associated with patients who are obese, yes. Obesity or those with poor MBO status, delayed gastric emptying, that would include the aspiration risk as well. What? Sorry, wait, blood pressure. Yes. Hindi, kasi magsasaka ba? Di pa hindi, kasi magsasaka. Ayun, meron. Lang po, aspiration lang po talaga. Aspiration. Usually po, their patients are, plans are to do a rapid sequence intubation. So for pre-oxygenation, may other techniques po. Yun naman. Pwede rin po yung tidal volume or tidal volume breathing for pwede po rin yung for pre-oxygenation, pwede po yung tidal volume breathing prior to the intubation as well. Wala na po yung exam. So obesity na yun. So obesity na yun. Obesity na. Hindi kasi kung malaki eh. Ibig ko na. Hindi kasi yan. Hindi yung mga. Decrease the risk for aspiration. So minimize to increase the gas intake by giving programs. Applying keeping pressure during intubation. NGT can also be done to lessen the gastric contents. Birch,
Ay, buka rin ba?
yung screenshot po.
Lim.
Hindi ko yun nasa tablet.
Alam mo lang bakit? Friend mo yan.